Hey, welcome back, Kim.
Thank you.
So
Happy
nice
to be
to
back.
see you. I have to say, for me personally, your presentation is so well organized and very impactful. I wish everybody could see that because I heard a stat on CBC about diabetes and how it's on the rise. 1 in 3 people.
About that, yeah.
Yeah, really across Canada, everybody. 1 in 3 people subject to type 2 diabetes, which is really, and a lot of it can be managed by lifestyle. Not always, not always. There is the exception, right, Kim?
Oh, definitely.
So I know Bonnie Bolger has listed a bunch of great questions. So Bonnie, do you want to start that way, Kim, or do you want to do a little bit of an overview? What would you like?
I'm happy to answer questions, and that might answer any overview things as well.
Okay.
Yep.
Bonnie, do
Okay,
you
well,
have your questions with you, or did
Well-
you want me?
you can ask them. And I had one other thing. I'll ask one thing first. I have a friend who is a teacher. She's bright and intelligent. And she has kind of had type 2 diabetes for a while, but it got really bad this past winter. They had to put her on huge amounts of insulin. And she'd say, I can't eat anything but wassa bread and peanut butter. And I kept saying, oh no, I think you have to eat better than that. And there's the Diabetes Resource Center. She is in Huntsville, but I said, I'm sure there's one there. But I could not get her to understand about eating. Like, is there a way to explain to people? Like, and she's smart. It was like she was in denial or something. I don't know what was going on with her.
It's quite possible. A lot of times people do get that mental block as to what they can and cannot do. They find something that works, and then after that, they say they can't do anything else. So it's quite possible, even though she is a very intelligent person, that she's just developed that mental block and denial. So it is a good idea, and I'm glad that you did recommend that she go and see a diabetes education center, because they might be able to work with her. Most education centers do have social workers to help with some of those mental blocks, to accept it a little bit more and be able to embrace the education a little bit better. It can be challenging. As I mentioned last time, there is such a strong correlation between mental health and chronic disease. And if she's been dealing with this for such a long time, and then all of a sudden it got worse, then it can really impact a person, because they all of a sudden feel that they've become a failure, that they failed themselves. And it's not that at all. And a lot of times it is just the disease process, because as I mentioned before as well, it's a progressive disease. So what might work for somebody one year doesn't work the next year. There might be added stresses. And I mean, COVID is a perfect example of incredible stress on people for many different reasons, both physical and mental. And that has really impacted people's blood sugars as well. People aren't as active, they're not as social, they're not eating as well as they used to. So just kind of breaking out of that a little bit, talking to someone outside of their friends and family, somebody that's kind of, what's the word? Indifferent, like not indifferent, but just not that personal connection that they can really express their feelings to, can be very beneficial. And just understanding that it's not anything that they've done. And sometimes you just need to get those reminders and back on track. So I think the fact that you recommended she touch base in Huntsville, I do believe has a diabetes education center. If not, there's one in Aurelia, that she connect with them. And a lot of us are doing it virtually as well, so she can book an
Oh, that's
appointment.
good. That's good to know. Would it be beneficial, Kim, if you have somebody who's having that issue, if you offered to accompany them? You know what I'm trying to say, Bonnie?
Like having a support
need that
person?
kind of support with them,
Yeah, we have support people come in with our clients all the time, whether it's in person or on the phone. And those support people will hear things differently than the person that's having those mental blocks, so that they can reinforce that information after the appointment.
So Bonnie, I've got your questions here. I can't even pronounce some of these words. Is Ozempic, is that the right
Yep.
pronunciation? And Noom injectable now become a norm in bleeding with blood, in dealing with blood sugars within the diabetes framework?
It has become quite a norm. Lots of people have found great success with the Ozempic. You've probably seen commercials for it on TV. So Ozempic is a, pardon?
Is that Noom? Is that what Noom is?
No, Noom is more of a psychological approach. I haven't done too much research on Noom itself, but the Ozempic itself is an injectable. So Noom is a service that you subscribe to, and they do more of the psychological changes in your mentality to change the way you're thinking about food and yourself. So lots of people do find great success on that. I did hear from somebody recently that they encourage skipping meals, which, if you have diabetes, isn't always great for your blood sugar control. But again, diabetes is such a personalized thing. Everybody responds differently. So it can work very well for some people with diabetes. But again, it's all about what you can stick to long term. So if somebody looks into Noom and they're like, no, I don't think that's for me, then that's fine. You don't have to do it. If somebody thinks, yes, this is a way that I can embrace a new lifestyle, then you can go that way. The Ozempic is an injectable medication that we do use very often for people with type 2 diabetes. And what that does is it has some effects on how your hormones are working. So it slows down digestion a little bit. It allows the insulin that you're producing to work longer so that you're going to see less of a spike in your blood sugars. But it also decreases your appetite. So people find that they get full faster, so they're not eating as much. And they do find that they have significant weight loss with it. It doesn't work for everybody, but it does work for a large population.
What's the impact on, are there any side effects? I guess that's what I'm looking for.
So the biggest side effects with the Ozempic is GI upset. So people will find they're nauseous. Some people will have diarrhea. Not as many people will have vomiting, but those are the major impacts of the Ozempic. But physicians start at a titration. So you start at a very low dose that's not helpful whatsoever, but it's just to get your body used to it. And then you go up a little bit. And then if your body's used to that, but you're not seeing the perfect, or I shouldn't say perfect, but if you're not seeing the positive impact that you're looking for, then they'd go up again to the next dose, which is usually the one that if you don't see the impact at the second dose, you'll see it at the third dose.
Has the stem cell procedure shown improvements in chronic issues like neuropathy, kidney function?
So stem cell research is still very new. It's a lot of clinical trials. There's not really any that I'm aware of. And we were actually talking about this with one of the pediatricians recently regarding type 1 diabetes. There's not a lot of information out there at this moment about this being a therapeutic treatment for diabetes. So it is very much still in the research stages. You might hear about pancreas transplants. So that is a thing. It's usually for people that are on dialysis so that their kidney function is no longer working properly. If they're a candidate for a kidney transplant, then they may, and they have type 1 diabetes, not type 2, but maybe type 2, they will be, after an assessment, they can decide, but they can become a candidate for a pancreatic transplant. That being said, insulin's a fairly easy injectable, not a lot of side effects with that, whereas with any sort of organ transplant, then you're taking medications, an anti-rejection medication that can give you a lot more side effects than your insulin would. So you're kind of trading one medication for another. So it's just depending on what's best for the person.
Okay, Debbie has a question. What is the current? Go ahead, Debbie, if you want.
Okay. I was just wondering what the consensus is now from the Diabetic Association on how many hours you should go between meals. I know for a while that, certain associations were saying you should eat every 2 hours. Then it was no, you should only eat 3 meals a day. And like, where is that at? And my second question was whether the Diabetes Canada recommends intermittent fasting.
So right now the recommendations are eating every 4 to 6 hours. If you want snacks in between, that's perfectly fine. But yes, I know that was the recommendation before, that you do have to eat every 2 hours, which no, if you're getting the nutrients that you need and you're getting your amount of carbs and your blood sugars are doing well, then every 4 to 6 hours is perfectly fine. Some people eat less at meals, so they want to have a little snack in between, and that's perfectly fine too. You just want to make sure you're not overdoing it at any particular time. Regarding the intermittent fasting, there's no real statement put out by Diabetes Canada, as far as I know, about promoting it. So again, it's just going with what was recommended in that, and I've heard this from the endocrinologists, so the diabetes specialists, that stick to whatever diet you can stick to, so not fluctuating. So if you're going to stick to intermittent fasting long term, then do that. It's just any diet that you go on can change your metabolism, and if you go back, then you might actually end up gaining more weight than you lost. So whatever diet you can stick to, that's the one you want to go with, because that's impacting your metabolism and how your body's metabolizing the foods.
So I know some people who've gone on a keto diet, but it's some of my son's friends did that and lost copious amounts of weight, but they went right back. As soon as they lost the weight, they went right back to eating the way they normally did, and they gained more weight. They really,
Yeah, that's perfect example of how it changes the metabolism, so that you might have been sitting at a certain weight that might have been higher than what you wanted it to be. But once you change that metabolism, then you can't metabolize the food the same way as you were before you took on that diet. So that's why we definitely encourage the lifestyle, because more people can manage that lifestyle change versus a quote unquote diet. We use the term diet for any way that you're eating, but it's just however you can maintain long term.
So your set point might drop then, if you do a diet and then you go, and then so that's what you don't want to happen. You want your metabolism to work and function so that you kind of burn those calories, I guess.
Yep,
eh?
Exactly.
Okay, Jill, go ahead.
I just have a general comment. I happen to, some of you do know this, but I happen to be a type 2 diabetic. So I've had a little bit of experience trying to manage that. But it just by coincidence, the University of Toronto, and its magazine that it puts out, it's sort of focused on the miracle of insulin as the 100-year celebration, of course, for the discovery of it. And I read the article. Two things that really jumped out at me, one of which you mentioned, Harriet, that almost 1 in 3 Canadians is living with a form of diabetes or with pre-diabetes. So if you look within our own little group of living fitters, well, I'm one, and there's probably a number of others, in our group, or who may move into the group as they become older, which is pretty scary in terms of numbers of a chronic illness. The other thing that the article mentioned is that it costs our healthcare system almost $30 billion a year. Now that's blew my mind away, actually, when I did read that. I have 2 comments. That I think diabetes is sort of a North American phenomenon as we get older. It doesn't happen, my understanding is, to quite the same degree in other cultures, which is interesting. And my question is, what can we do to prevent this diabetes as much as we can? And will diabetes, if you're a diabetic type 2, eventually, if you live long enough, will you become a type 1, or what are the statistics around that? If you're managing your diabetes type 2, and will it progress to less production of insulin, or your insulin becomes even less effective, even though you have been managing it with diet, which I'm very fortunate I have been able to do that, and exercise without having to go on medication. But what are the stats that tell you, even if you do all the things, quotes, that you can do to help yourself progressing to becoming diabetic type 1?
So I would have to do some research on that, Jill. That's a fantastic question. I don't know the exact stats for that, because the thing with diabetes, as I said, is progressive. So what's happening is, because you're managing with your lifestyle, which is fantastic, you're allowing your pancreas to work properly. So you're not putting undue stress on your pancreas. So it's not getting too tired. It's not overworking itself. So I think it's going, from my knowledge of diabetes in itself, I don't know if there will be a specific statistic on that, because it really is going to be person dependent. And just like with any disease, any cancer, any heart condition, it's really going to depend on your genetics. It's going to depend on how kind you are to your body, the foods that you're taking in, because if you're stressing your body too much in any fashion, then you're at increased risk for that organ failure. So your pancreas is just another organ that can be affected just like any other body. So I will definitely look into a statistic for you, but because you've been doing so well, I would imagine that like you're looking far down the road before you would get to a point where your body's not producing any insulin anymore, which would be type 1. People with type 2 diabetes may go on insulin, and many do, but it's not so much because their body's no longer producing any insulin, it's just not producing as much. So if you're on insulin, it doesn't automatically make you a type 1. It just means you're not making as much insulin as your body needs. So I unfortunately can't give you a timeline, but I will see if there's a statistic to say whether people with type 2 diabetes progress to the point where they're not making enough, and how many, and at what point in their disease process. So I will make note of that.
Roseanne, you have a question?
Yeah, my question is specifically related to obesity as it relates to early onset diabetes, specifically in maybe children 7 to 14 that are obese. And are there any markers in blood work that you would look for besides just the regular fasting blood sugars, the routine blood sugars, the HbA1cs? Is there anything that families should be looking for?
So typically with childhood obesity, a lot of times, especially in girls, type 2 diabetes will present itself around the time of the age of 12. That's when the hormones are really vamping up for puberty. Boys are a little bit more flexible in that timing because they don't have the same insulin resistance as the girls do during that pubertal onset. So when we're looking at children with obesity, the physicians typically do counseling with dietitians to encourage healthy lifestyle. They may be looking at liver functions to see if there's any fatty liver issues. They are going to be looking at different areas in the body for signs of insulin resistance. So any dark markings, usually in the folds of the neck or on the arms, you can get some dark markings, which is an indication of insulin resistance. So it's called acanthosis nigricans, if you've ever heard of that. And you may notice that in anybody, whether child or adult, that is overweight. If you get those dark markings, then that's showing signs of insulin resistance. Doesn't mean that that person has type 2 diabetes, but they are showing that they can become insulin resistant. So, so those are typical things that we're looking for in kids that have obesity. So the typical things that you want to be doing is encouraging the healthy lifestyles as much as possible, trying to minimize or reduce screen time, getting them out, getting them active, getting maybe some more nutritious foods, keeping away from the pops, doing more water. Those are definitely things that we would encourage because with COVID, we do know that this has been a huge impact on kids because they're now doing they were doing virtual learning. So they were sitting in front of a computer more often and not going out for recess and not doing their gym class. So they're being put at an increased risk for obesity. Does that answer your question, Roseanne?
What about blood work and markers? Like if they went for blood work, besides the blood sugars and the HbA1c, is there anything specific they'd be looking for in children besides the fatty liver?
That's typically what they're looking for. So they're
Okay.
looking for the fatty liver. They're looking at their, whether it's a HbA1c or they're looking at a random sugar as well or a fasting sugar. Those are the typical things that they're looking for.
Okay.
Whenever you're testing for impaired glucose, they're usually looking for that fasting blood sugar. And I apologize, I was made aware after the presentation that you didn't see all those slides last time. So I can share those again if that's of interest, because there are slides that show those areas where you're being put more at risk with fasting blood sugar or an A1C for type 2 diabetes, which is the same parameters for a child as it is for an adult.
Claire, did you have a recommendation there? Or you had something you wanted to share?
Well, yes, I just put my thing back on. My grandson was diagnosed with type 1 diabetes at 2. And what we all had to read, I don't know if does this show backwards, think like a pancreas?
No, we
like
can see it. Yeah.
Okay, because when I see it, it's backwards. And it really explains well the difference, between type 1 and type 2. And from what the discussion that I hear about a blood marker, I worked in genetics for a long time, and I don't understand why they haven't kind of been able to assign the gene to it, because the pancreas, the islet of Langerhans, the little cells that produce it, I can't understand why they can't do stem cell. I heard one of the girls talk about stem cell. There has been a lot of research, but it hasn't led anywhere, because I know my son's really been looking into it to see if it works, because if you're that young, you got a long life ahead of you to be able to have to manage the insulin. So anyways, I just thought if there is someone, I was Bonnie's friend, I'm not too sure. There might be one for type 2 like this, because maybe it would help her friend to kind of understand better what's at stake, and managing her diabetes, because it's not everyone like Jill who can manage it that well. And I know they really promote doing it like Jill if you can, because it's so much healthier.
Yeah, but again, genetics does play a role in it,
Yes,
as you mentioned. So some people, they just genetically can't manage completely with.
Oh, no, they won't be able to. It depends how much resistant their cells are to accepting the insulin to manage the sugar metabolism. So
yeah, and that book is a fantastic book. So that book is written by somebody who has type 1 diabetes, and he's also, I can't remember the exact title. He is certified diabetes educator, insulin pump user, trainer, CGM user trainer, and master's level exercise physiologist. So I have also read this book. I think it's fantastic. He is very, very knowledgeable. So if you know anybody in your life that has type 1 diabetes, it is a really good resource. So yeah, with the genetic component of it, if there is any question as to whether somebody has type 1 or type 2 diabetes, there are genetic markers that they do test for to see if they're making any insulin or if they have auto antibodies that are killing the cells in the pancreas that are producing the insulin. So as Claire mentioned, so there is some genetic testing for that, but yeah, unfortunately, for whatever reason, there just isn't that that stem cell process out in the public that's not in research trials just yet.
I had a question, but it just flew out of my head. But
Oh,
there are
sorry.
more new questions. What is the current recommendation for a number of hours between meals for type 2 diabetics?
Oh.
No, that was already addressed, Harriet. That was from me. Thank you.
Does the Diabetes Association recommend intermittent fasting? That's
Yeah,
been-
so that was
okay.
Debbie's question as
Yeah,
well.
that was dead. Oh, two more. Wait a minute. All right. Jill has another comment. Pat, we'll answer this question first, Jill, if that's okay.
Yeah.
Sweeteners other than sugar for children, what do you recommend?
So
I have a grandson who is quite overweight and we're concerned. He's 8 years old. And he often, when he comes to visit, he will, direct me to sugarless drinks like Propel and stuff like this. And I look at what the sweetener is in it. He goes through them like water. I mean, he really has I don't know, an affinity for whatever kind of sweetener is in them. So I'm just wondering, is that, adding to his problems, or I'm just not sure because he doesn't like to drink water.
So sweeteners, from my understanding, and I have talked to our registered dietitian about this, are safe. We know that all sweeteners on the market right now are safe in pregnancy, so they would be safe in children as well. Do you know the sweetener that's used in the Propel?
I don't offhand.
Okay.
No, I don't. I'm not sure what it is. I know that it's not aspartame.
Okay. So most of those sweeteners, like the limits are pretty high, but I'm not really that surprised at what you're saying about the fact that he's, from what I'm gathering, is more or less drinking one after another. Because what happens is the body is getting that sense. So if he's somebody that typically really enjoys sweets, he's going to see some blood sugar spikes, as any of us do. So whether we have diabetes or not, our blood sugars do go up and they come down. That's just normal pathophysiology of how the sugar breaks down in our body. So what happens is his body is getting that sensation that his blood sugar is going up, but it's not actually going up. And then it's going to be craving that spike again. So a lot of people that are switching from, say, a regular pop to a diet pop, their body is used to that spike. So they're craving that spike. That's what they want. That's what they need. So when you're switching to one with a sweetener, you kind of end up just going one after another, after another, after another, because the body's trying to get that spike. So it is ideal if he can drink some water in between just to kind of settle things out a little bit. But as for how much is okay for him to be drinking, I'd have to look into that as well, which I'm happy to look into all these questions, and I can send them back to Harriet and maybe she can disperse the answers.
Thanks a lot. That's great.
We've gone are the days when, I don't know, I never thought I'd say this, but when we were kids, getting a chip or a pop once a week, maybe once a month for some of us, was a huge treat. And now it can be a daily thing, which is really, and we're our own worst enemy, I would say. Jill, go ahead with your comment.
Yes, Kimberly, I have a book also. I'm not sure if you have had anything much to do with Dr. Jason Fung's thoughts. I don't know if you can see this, if it's reversed in the. He's written the Diabetes Code. He also was author of the Obesity Code. Do you have any comments about his work? He very much focuses in on lifestyle change and the fact in North America we have so much added sugar to our foods that we eat. And he very much promotes the keto diet sort of philosophy, amongst other things. But I just wondered if you had any comments about his work.
No, people have found great success in his work, but I just want to go back to the going with the diet that works best for you and that you can follow long term. So if you can follow that super low carb diet, if you can follow the ketogenic diet, and it's not going to impact you financially too much, and it's not something you're going to struggle with, then you can do that. But it's just that, as I mentioned before, if you try it and it doesn't work for you, you do end up gaining more weight than you lose just because of that change in your metabolism. So I have nothing negative to say about him. I think if that's something that people can do and they can follow, then by all means, because it has shown like positive improvements for people. But it is something that I have noticed in my practice and out in the community, that a lot of people that try some of these diets do end up having worse outcomes afterwards. So just really researching what's going to be best for you. And I'm sorry, Jill, I did want to mention, you had said about this being a North American pandemic, more or less, and that is true, but it's also in European countries as well. So the first world countries like England and France, not so much France, but England for sure, this is definitely an issue as well.
Okay, thank you.
Okay. I have a question, Kim. When we talk about 1 in 3, can you give us I think you probably told us this in the last presentation, but I'm not sure. So 1 in 3, in Canadian are diagnosed every hour or something. I saw, I heard this on, I don't remember the exact stat, but I'm wondering if you could break that down just a little further. What age groups, I understand the age group is getting lower and lower, that we're, children are being diagnosed with type 2. So can you give us a little bit more information about that? Male, female?
So from what I've read, there's, it doesn't really break it down too much. I'm just going to pull up the last presentation and see what I put in there. Sorry, going to take a second here. Okay, so I'm just going to share my screen here for a second. Can we see this?
Yes.
Okay. So pre-diabetes, type 1 diabetes, type 2 diabetes, there's somebody, like you mentioned, pretty much every hour is diagnosed with some type of diabetes. So pre-diabetes just means you're at higher risk. These are, as I mentioned before, the fasting blood sugars, the A1C results. When you're looking at your blood work, especially if you do like labs or your doctor provides you with your printouts of your blood work, these are the indicators that you're at risk for diabetes. Your blood sugars are normal, you have pre-diabetes, or you have diabetes. Okay, so type 2 diabetes is very much based on family history, whereas 75 to 90% of people diagnosed with type 2 diabetes have a primary family member, so a sibling or a parent that has type 2 diabetes. Other things that put people at risk of developing diabetes are if they're a child of a mother who had gestational diabetes. If they do have a strong family history of diabetes, even in the grandparents' age, there is lots of racial cultural impacts. There are certain ethnic groups that are at higher risk of developing the diabetes. Again, that is based on genetics. So I'm not quite sure if they've compiled it all to break it down specifically to male, female, or age group in itself. But typically by the time somebody's at age 40, they are going to be starting to do these A1C test results, or they're going to be doing your fasting or your random blood sugar to see if you are at a higher risk of developing diabetes. If you have more markers that are an indication, so if you are overweight, if you have that high family risk, if you've shown any sort of insulin resistance in the past, as in, did you have gestational diabetes when you were pregnant? Then they might be testing a little bit more often. If things are coming back normal at the age of 40, they typically test every 3 years. If there's anything that's showing you're at higher risk, they're going to test a little bit more frequently. And then with the kids, once they start showing signs of obesity, if they're showing any of those signs of the acanthosis nigricans, so that darkening in the folds of the skin, then they are going to be testing them a little bit more often too. So I can look up the stats for the specific breakdown. I will look that up.
Okay, we had another question. Oh, this is a comment from Seni. In Colombia, that's where Seni, that's her home base. The stats are, there are lower cases. There are 3 persons with diabetes for each 100 people of the population.
Okay.
That must have something to do with diet, lifestyle.
Yeah, it can have a huge effect on lifestyle. We do know that the indigenous population is at higher risk of type 2 diabetes because there has been such a change in their diet over the past few years, that their bodies haven't quite caught up to all the processed sugars that are now in the diets, whereas they weren't before. So if you're looking at cultures that are eating what their ancestors ate, then they're at lower risk of developing type 2 diabetes. That's huge. That's a huge impact. Just because our body has developed this way of processing foods, that when you diverge from that and you incorporate more processed foods, when you typically ate more natural foods, more plants, more fish, like corns for your starches, potatoes, like those whole foods, then you bring in the processed foods and your body just, it's not equipped to deal with that sugar load anymore. So that's where we also highly encourage doing whole foods more than processed foods, and trying to eat based on your culture as well.
I asked Seni, I guess she's busy, but I wondered what their daily, what is their food, their staples,
Yeah, that'd be interesting to know.
To know from their country. But any other questions or thoughts? Do you mind stop screen sharing, please, Kim?
Oh, sorry.
That's all right. Yeah. Okay.
I was just wondering if you could speak to like diet. Should you always have a protein when you're having a starch, that sort of thing, to slow down the absorption? Is there any kind of ratio that you should be eating? I mean, even for anybody, just in terms of getting those blood sugar spikes.
Yeah, so we always encourage having high fiber as much as possible, because that slows down the release of the sugars. We encourage having those proteins or a little bit of fat. So most proteins do have a little bit of fat with it, but when you're having those high fibers, when you're having that protein or that fat with your carbohydrates, so if you're having some crackers with cheese or peanut butter, you're having some fat and protein with it. it slows down the release of the sugars so that your blood sugars are going more on a gradual curve. Whereas if you just have some chips, let's say, that's a bad example because that's also fatty. Say you're just having a big bowl of mashed potatoes because you're going to be having some gravy on there as well, but you're like, oh, I don't want that extra fat, I'm just going to have that big bowl of mashed potatoes, then you're going to see more of a spike in your blood sugars. So you want to have that higher fiber, you want to have that protein, that fat, to slow down the release of the sugar so your body can keep up with it faster.
Okay.
Can I make a comment here? I have struggled with my weight pretty much all my adult life. And I don't think there's a diet out there that I haven't tried. And you're absolutely right. I now fully believe, finally believe that doing all the yo-yo diets has caused more problems than, because I really don't think that I metabolize my food properly anymore. The one thing that I have learned though, and I don't know if you'll agree with this or not, Kim, but especially where diabetes is concerned, because it's something that concerns me, my fasting blood sugar is always tested high. And I have found that I don't eat a lot of sugar, at least refined sugar. I know there's a lot of hidden sugars that are hard to avoid, but the carbohydrates, which I know get converted into a sugar, are the things that really cause me more problem than anything. And if I can control my carbohydrates, I can control a lot of things. And the more carbohydrates I eat, the more I want more carbohydrates. It's the brain that give me more, like you were explaining about somebody's grandson, Patty's grandson, with the sugary drinks. The more you have, your brain is saying, give me more, give me more.
Yeah.
And I find that most people, when they're talking about diabetes, they're concerned about sugar. When personally for myself, I find that I feel a whole lot better if I control my carbs because I'm not craving more. Would you agree with that?
I would, yeah. So the more processed the sugars are, the higher the spike. And then your body's going to crave that spike because it gives you a bit of a high. And then when you crash down, because when you have that spike, you tend to crash, then your body wants to get back to that feel good, because when you're crashing down, you don't feel good. So that's that negative response from those more refined sugars. So when you're getting your sugars more from the whole foods, like you're getting the fruits and you're getting the starches from, say, a cob of corn or some potatoes or a little bit of pasta, a little bit of rice, you're not going to be craving that as much because you're not going to be getting as much of that spike. So absolutely, I agree with you that if you're having more of those refined sugars, then you are going to be craving more and more. Whereas if you're eating more of that balanced diet and you're getting your carbs from different sources, then your body's not going to crave it as much. I can't say that it's going to eliminate those cravings, but you're not going to crave it as much. One thing that I've noticed even personally is if I hit pretty much all my food groups, I have less cravings. So if I'm getting my dairy in, if I'm getting my fruits in, if I'm getting my vegetables in, if I'm getting my starches in and my protein, I don't find that I really have a lot of cravings for the junk food or the sweets, except for chocolate, because I'm sorry, that's my genetics. Thanks, Mom. So just trying to go with like the darker chocolates in that instance is a little bit better. But I do find if you're getting more of that balance in, then yeah, you do find that those cravings, and again, this is personal, but I've also heard other people say that, is you don't have as many of those cravings. So I absolutely agree with you, Debbie.
Jenny says that that's the bad thing with carbohydrates. They cause, I don't really understand your statement, but same happens to me with bread. As the more I eat, the more I want.
So it depends on the type of breads you're eating as well. And some people just, it's very physiological, right? you have in that mental aspect of it, you get that comfort from carbs. Like if you have a breakup or if you know, have a bad day, what is the typical foods people go to? It's those carbs, it's those casseroles, it's that ice cream, it's the junk food. So we get comfort from that higher sugar. So it's just a matter of balancing it out, and it's, sorry. So it's just a matter of balancing out and going for the healthier carbs when you are craving that comfort food.
Yeah. Senny has a newborn. She's 5 months old.
Oh, congratulations.
Her name is Matilda. So I imagine you want to feed her the best way you can, eh, Senny? Yeah. Can you unmute and tell us a little bit about Colombia? What's the daily what is it? Staple. What's the staple in Colombia? For
Could you clarify what a staple is?
a staple is something that you would eat every day.
Oh, okay, yeah. So is wild different from here? Because we have like a statement every day, like we eat on breakfast, we eat as a king. On lunch, we eat as a rey, as a princess, and on dinner we eat as a homeless. That's kind of the statement.
You eat like a king, you eat like a princess, and then you eat like
a homeless.
Homeless.
So we try to reduce more our ingestion, our eating. So our breakfast is bigger. It's like the principal food for us. We don't used to eat sugar on breakfast. We don't used to eat like waffles, like pancakes. We don't used to. It's not a common food there. We just eat like eggs, coffee with milk, toast, some bread as well, and typical food that we have there. And for lunch, different from here, is another big food for us. So our lunch is rice, cereal. So we always have like rice, the proteins, like chicken, meat, pork, and fish, a lot of fish, salads. We like it a lot as well. And in the evening, that's our like plain food, like kind of a tea with toast. It's like a snacks. It's not a main food. So I know that here at 5 is like the main food, right? And at noon you take like a snacks, something like that. So we do it in an opposite way there.
Yeah, and that's actually not bad at all, because typically you're more active during the morning and the afternoon. So having more food in the morning and the afternoon is beneficial to compensate that energy release, whereas in the evenings we're a little bit more sedentary. One issue, if you do have diabetes though, is your body is naturally a little bit more insulin resistant first thing in the morning. So if a person has too many carbs first thing in the morning, then they might have their blood sugars go up too high. So that's just kind of a physiological aspect. So we tend to kind of aim for that 30 to 45 grams of carbs first thing in the morning, but you can still eat lots of proteins to keep that energy up. So having lots of vegetables, lots of proteins, just kind of reducing on the carbs a little bit. So you can still eat like a king at breakfast time, which is not a bad thing. You just want to watch how many carbs you're having at breakfast time if your body is naturally more insulin resistant in the morning, which means you're not making enough or your body can't use the insulin as effectively. So I think that's a fantastic way of eating.
Thanks for mentioning. And another funny thing is that, well, it's not kind of funny, but I just want to share with you. Back home, it's not easy to afford a car.
Okay.
You know, it's not easy. And because we have like a summertime all the year, we walk a lot.
Yeah.
You know, so our exercise is like we are not that sedentary as you mentioned. Yeah. We just move a lot. For a car is like you can work all your life and even don't make it, you know. So it's fun. So it forces you to do some exercise.
Yeah, no, that's perfect. And
Yeah.
yeah, it sounds like a different way of living, but a good way of living at the same time.
Okay, any more questions or comments? Well, first of all, I want to thank everybody for all the questions and comments. We
Yeah, it's
all
been
learn from
fantastic.
each other, a wisdom of the group, Kim.
Yeah, I think it's fantastic. I appreciate everybody's input and questions.
Yeah, and I know we all appreciate you coming on again and broadening that information you gave us. And I haven't put the video up yet, but I will. We've had a little bit of a under construction with the videos,
Okay.
but they are going to go up today. I think today will be the day.
Oh,
Okay,
perfect.
for everyone, and you can go back and review. And may I suggest that if you have family and you're worried or you're about sugar, and you could pull up one of those videos and let your family see them, or use it as maybe a starting point for a discussion, especially when you have grandchildren. It might be helpful, but I know for my family, I can't say that out loud. It would have to be running in the background kind of thing.
Right.
So Kim, thank you so much. And thank you to your mom for recommending that we have you as a guest. You're very, very knowledgeable and very informative. And we're lucky to have you in Northern Ontario at our hospital, that's for sure. So
Well, thank you. It's been my pleasure. And I really appreciate all the questions and comments. And I've got to say, you ladies made me think. So I appreciate that. And I'll look into those few questions. And Harriet, if it's okay, I'll respond to you.
Yeah,
And
I
then
send
you
a
can just-
weekly email and I can send that on to everyone.
Okay, so I should have some answers for you by the end of the week.
Wonderful.
Okay.
Okay.
All right. Well,
thanks
thank you
again.
very much, ladies,
Thank
for
you
having
again.
me.
Thank you. Great discussion. Okay.